Vitamin K will be there in the blood circulation in patients with obstructive jaundice.
No, sir. Vitamin K absorption does not take place because of the obstruction. It happens in intestine, but the synthesis in the liver.
No,
And
vitamin K is not synthesized in the liver. Vitamin K has to be, through the food. Vitamin K is
absorption.
now why vitamin K may not be absorbed in obstructive jaundice?
Intrahepatic circulation is blocked, sir. So
Nothing to do with enterohepatic circulation. Vitamin K requires what? What sort of a vitamin it is?
fats.
It's a fat soluble vitamin, isn't it?
Yes, sir.
Vitamin A, D, E, K, they are
Yes,
fat.
sir. Fat soluble.
They require what for their absorption? They require bile salts for their absorption.
Yes, sir.
And whenever there is obstructive jaundice, the bile is not entering into the intestines. When bile is not entering into the intestines, bile salts are not there. Already we discussed. So vitamin K cannot be absorbed. If vitamin K cannot be absorbed, so though coagulation factors are produced in the liver in obstructive jaundice, but they cannot be activated because vitamin K is not there.
Yes.
Why should you know as anesthesiologist about these things? Suppose a patient is there with INR is increased. Suppose if it is obstructive jaundice, how do you manage? And if it is because of end-stage liver disease, how do you manage?
Unless the obstruction is removed,
No. Before that, you have to make sure that if you subject these patients for surgery, so they are going to bleed to death. You have to optimize their INR before taking up for surgery. So if it is due to obstructive jaundice, how you can optimize? What is lacking there? In obstructive jaundice, why they have prolonged INR? Because vitamin K is not there. It's
not there. Yes, sir. We can give vitamin K injections or
you give injection.
injection. Yes, sir.
If you are giving orally, it will not be absorbed.
Yes,
but
sir.
directly you give IV,
yes, sir.
so it goes on, the INR will become normalized.
Yes, sir.
Because the coagulation factors are synthesized by the liver, but the coagulation factors are not getting activated. You require vitamin K. So you give parenteral vitamin K.
Yes, sir.
So should you give vitamin K intramuscular or intravenous?
Intramuscular.
Intramuscular. For these patients with high INR, increased INR, what will happen? If you give vitamin K intramuscularly in a patient who has higher INR or prolonged prothrombin time, what will happen? There where you have injected. There will be a big hematoma. So should you give intravenous or intramuscular?
Intravenous.
Now you realize, isn't it? These are some, minor questions or simple questions we'll be asking you in the exam. And you should be able to, have your common sense you should use, logic you should use and answer. Otherwise, you should know also. So parenteral vitamin K. Suppose if it is because of end-stage liver disease or a chronic liver disease, INR is prolonged. Does giving vitamin K, will it improve?
No, sir.
Yeah, it will not reduce INR. Why?
Clotting factor synthesis itself is not happening. So vitamin K, even if it is given, will not get activated.
It cannot help, isn't it? Much. Yes. Unless there is intrahepatic cholestasis also is having some amount of effect on prolonging the INR. Otherwise, usually the vitamin K, giving vitamin K may not help. So what you should do in optimizing the INR in such patients?
Blood products transfusion.
What blood products?
Fresh frozen plasma, cryoprecipitate.
You might have to give fresh frozen plasma, cryoprecipitate, or even, prothrombin complex concentrate, PCC. So these are the things we have to give, and platelets also. We'll come to platelets also. And these are the things you'll have to give in order to maintain the hemostasis as far as the patient is concerned, isn't it? Now coming to the platelets. Now what happens to the platelets in these patients?
Decreased, sir.
Decreased. Why? There can be thrombocytopenia in a patient with chronic liver disease.
Thrombopoietin. Not.
Pardon?
Thrombopoietin is not.
Yeah, one is thrombopoietin, which is synthesized by the liver, not
It's
be
not synthesized.
because there is liver disease is there. So that is how
Yes.
thrombopoietin is required for the production of thrombocytes. So thrombocytes may be reduced. What is the other cause of thrombocytopenia? And it may be the major cause. What happens to the spleen in portal hypertension patient?
It will be enlarged, sir. So,
So,
hypersplenism.
so because of that,
There'll be increased RBC destructions and platelet destructions will also.
yeah. So there can be sequestration of these platelets in the spleen and they get destroyed there. So that is the reason why these patients also can have thrombocytopenia. So they may require even platelet transfusions before taking up. So you have to get a thrombocyte estimated also. Okay. So that is how the coagulation problems can be there whenever there is end-stage liver disease. Also coagulation problems can be there whenever there is obstructive jaundice. And that is why INR is a very important factor as far as when you're assessing these patients using Child-Turcotte Pukes criteria, isn't it? Child's criteria, Child's Turcotte criteria, Pukes criteria. So INR and prothrombin time is one of the very important things other than albumin also, isn't it?
Yeah.
So coming to bilirubin metabolism, now why there will be jaundice in these patients with end-stage liver disease and in obstructive jaundice and in prehepatic jaundice? Well, can you just explain about the bilirubin metabolism? How bilirubin is formed, where it is formed, and entire steps of bilirubin metabolism. Again, very commonly asked question in the exam.
Heme will be broken down into.
So hemoglobin is broken down, isn't it? After
into heme,
the RBCs have got a life of say about 120 days, 90 days to 120 days. So then once their life is over, they die. That means they break down. And once they break down, the heme is separated from the globin.
Yes, sir.
Globin also comes out and heme is separated from the globin. Yes, and where does this occur? The separation of heme and globin.
Spleen.
Yeah, in reticular endothelial system of liver and spleen. So now what happens to the heme?
Through heme oxygenase, heme oxygenase gets converted into biliverdin.
So heme gets broken down to biliverdin, right? Then what happens to biliverdin?
This biliverdin gets converted into bilirubin.
Bilirubin is very good.
And it enters.
How does it enter the liver? In combination with something? In combination with albumin.
Yes, sir.
Albumin carries bilirubin to the liver.
Liver.
And in the liver, what happens to this? Is it water soluble or non-water soluble? This bilirubin.
This is non-soluble, sir. It gets conjugated and then becomes water soluble.
It is not water soluble, isn't it?
Yes, sir.
So now it has to be conjugated the liver by the hepatocytes. Conjugation occurs in the hepatocytes, and then now the bilirubin that is formed is a conjugated bilirubin. It is a water soluble bilirubin. What happens to this water soluble bilirubin?
It will be secreted along the bile.
Yeah, it is released into the bile. Okay, yes. Then it comes through the bile into intestines.
Intestines, yes.
Isn't it? It is the bile is secreted into the intestines. You have right bile duct, the left bile duct, they form the
Common hepatic.
hepatic duct, and combination with cystic duct form the common
bile
duct. And both common bile
duct
and the pancreatic duct
pancreatic
will open through the ample or water into the duodenum. That is the anatomy.
Yes, sir.
The anatomy you should know in thoroughly. Okay. Now this conjugated bilirubin, which is water soluble, will enter into the intestines. What happens to this bilirubin now? Is it acted upon by anything there in the intestines? Bilirubin metabolism, invariably you will be asked in the exam, in the practical exam.
Yes, sir.
Because it is acted upon by the bacteria in the intestines and convert that into urobilinogen and stercobilinogen.
Urobilinogen.
And there is the stercobilinogen and urobilinogen is the one which produces color to the fecal matter.
Color for urine and stools.
And urobilinogen gets back into the circulation through enterohepatic circulation, back into the liver and then back into the circulation. And it is because it is water soluble, it can be excreted through the urine. And it gives color to the urine. And it is one of the bile pigments, the urobilinogen. You know, bile pigments always we'll be talking about. So that is the one which produces color to the urine. Now, why should you know about this bilirubin metabolism? Now, in the beginning only, we were discussing about classification of jaundice, prehepatic, hepatic, and posthepatic. What happens to bilirubin in the prehepatic jaundice?
Increased unconjugated bilirubin will be there.
Yeah, because there will be so much destruction of the RBCs, so much bilirubin is produced, and liver has got a threshold for conjugating this bilirubin. Excess of this bilirubin, if it is produced, the liver will not be able to conjugate it completely. So there will be so much of unconjugated bilirubin which will be there in the circulation. And that is the one which produces jaundice. And that is why in prehepatic jaundice, which type of bilirubin will be increased?
Unconjugated.
The unconjugated bilirubin will be increased, and it is also called as indirect bilirubin.
Indirect.
It is called as indirect bilirubin, isn't it? So that is why whenever you get in the lab reports, you get the total bilirubin, and also you get how much is the indirect bilirubin and how much is the direct bilirubin.
Direct bilirubin.
In prehepatic jaundice, the total bilirubin will be increased. Out of that, indirect bilirubin component will be much higher. That's how by looking at these, direct and indirect bilirubin, you can say whether it is prehepatic or not. So if indirect bilirubin is much higher, you can say it's a prehepatic jaundice.
Yes.
Okay. So now in post-hepatic jaundice, now which particular part of the bilirubin will be increased? Is it direct or indirect?
Direct bilirubin.
Yeah, direct is the conjugated bilirubin because it is already conjugated and is not able to enter into the intestines, isn't it? So it gets released into the systemic circulation. So the total bilirubin will be increased. Out of the total bilirubin, it is always the conjugated bilirubin will be increased more. So if there is other signs of obstructive jaundice and also the conjugated bilirubin is more in the blood, you can say it is due to obstructive jaundice, isn't it?
Yes.
Whereas if it is hepatic jaundice, the problem is within the liver, like your patient has got a problem in the liver, end-stage liver disease. Which type of bilirubin will be increased? Is it indirect or the direct bilirubin?
Both will be increased.
Both will be increased depending on again which stage the patient is having. So if the patient is having an intrahepatic cholestasis as the predominant thing, so then actually the direct bilirubin will be more, slightly on the upper side. If there is no intrahepatic cholestasis, then there can be unconjugated bilirubin can be higher because the liver is not able to conjugate. So both types can be increased depending on what state the patient is having. So is it intrahepatic cholestasis is there or not? So that is why, the bilirubin metabolism is very, very important for us. And one more thing you should always remember that whenever bilirubin starts increasing, the maximum increase in obstructive jaundice will occur, but it will not be more than 35 milligrams. Why it will not be more than 35 milligrams? That's usually the maximum. Why it cannot go to 40, 45 like?
It will get excreted before that. So.
Yes. Once it goes to nearly 35, there is a soluble bilirubin, isn't it? So kidney can excrete it because it is water soluble. So kidneys will start excreting this bilirubin. So that's how, the maximum level of bilirubin in the blood that can occur is 35 milligrams per deciliter. So that is why this is one of the liver functions, which is very, very important for us to know about. And any another problem again is the formation of the bile is another function of the liver. And formation of the bile means it is always the bile, salts. I told you that the folic acid and deoxycholic acid, they are very, very important. And whenever there is obstructive jaundice is there, these cannot be entering into the intestines. So they accumulate and they can produce, as far as the skin is concerned, pruritus. If they accumulate in the heart, what they can produce? Bile salts accumulation in obstructive jaundice in the heart. They can produce bradycardia, severe and bradyarrhythmia, especially deposition of these and the SA node, the AP node, the conduction system. So they can produce a bit of bradyarrhythmias. So that is another very important thing you should always remember that occurs in obstructive jaundice. Okay. Now, coming back to the portal hypertension and what all the problems associated with portal hypertension. You said that, hepatic venous pressure gradient, if it is more than 10, it is a severe form of portal hypertension. So what are the problems associated with portal hypertension, which is very important for us to know?
Will be prone to varices bleeding.
Yeah, one is esophageal varices because the back pressure effect, because the portal vein is formed by supramesenteric and splenic veins. So back pressure effect. One is esophageal varices is very important. So why should you know that whether they may have esophageal, even your patient may have esophageal varices. So why should you know?
So they might become anemic. Yeah, so it's the portal bleeding can happen. So
A massive hemorrhage can occur. These can open up, and the patient can have massive hematemesis. And if you don't treat, he may even die, isn't it?
Yes, sir. Yes, sir.
Many times you may be asked about how do you manage the massive hematemesis as a result of rupture of the esophageal varices. That is one very important thing. Second thing is, for example, now this patient develops an obstruction of the hernia. He has got hernia, isn't it?
Yes, sir.
What you should be very careful with for such patients. Obstruction means he may have intestinal obstruction also, isn't it? Obstructive hernia getting obstructed means the intestinal obstruction will be there. So usually what is one of the important things you will be doing in order to reduce the distension?
Ascitic.
No, ascites is nothing to do with intestinal obstruction. Hernia, he has got hernia.
Manual reduction.
No. You'll put a Rayleigh tube, isn't it?
Yes, sir.
Are you not putting in intestinal obstruction Rayleigh tube?
Yes, sir. Rayleigh tube.
Can you pass a Rayleigh tube blindly in these patients with esophageal?
No, sir. We might rupture the.
Yeah, you rupture the esophageal varices and patient ends up with massive hematemesis and even he require massive blood transfusion. He can even die when you are just, simply without knowing you are introducing a Rayleigh tube. So very important. So that is why you should know that the esophageal varices is one of the problems with portal hypertension. Okay, what are the effects of portal hypertension on the lungs, which is called as hepatopulmonary syndrome and portopulmonary hypertension? Just tell about the hepatopulmonary syndrome.
So it's a triads of in a patient with
liver disease, patient will also have the pulmonary arterial pressure gradient of less than 80 and intrapulmonary vascular dilatation
and pulmonary hypertension.
Now, why intrapulmonary vascular dilatations occur? They are called as IPVDs.
Yes.
The IPVD occur.
Presence of the vasodilators which are produced like nitric acid or intestinal acid peptides or natriuretic peptide are produced in excess which are not able to get excreted. They get accumulated in the pulmonary vasculature causing dilatation of the pulmonary capillaries.
Now,
Which
normally
causes,
where the vasodilator substances are metabolized, where they get metabolized? They get metabolized in the liver.
metabolized by liver.
So liver is failing. So all these enter into the systemic circulation. Vasodilator substances, including nitric oxide.
Yes.
So they produce vasodilatation of the pulmonary vessels. Once the vasodilatation of the pulmonary vessels occur, which is called as IPVD, intrapulmonary vasodilatation, what is the problem there? Why the patients will develop hypoxia?
Because of pulmonary vascular dilatation, the oxygen is not
Pardon?
getting transferred to the innermost part of the
No, why patients will have hypoxia if there is IPVD? Now, what happens to the pulmonary hypoxic vasoconstriction, HPV? Will it get inhibited, HPV? Normally, there is certain zones of the lung.
Yes, sir.
There is no ventilation. The vessels supplying these non-ventilatory zones of the lung are constricted, isn't it?
Constricted. Yes, sir.
That is what is called as hypoxic pulmonary vasoconstriction or HPV.
Yes, sir.
Now, once there are so much of vasodilatory substances are released and then enter the lung, all these vessels which should have been constricted, they get dilated. And they are supplying the non-ventilated zones of the lung. That means the alveoli are collapsed. So there is no exchange of oxygen. So that is the reason body will try to protect the amount of blood flowing across these areas. It tries to reduce the amount of blood flow across these areas. Now, vasodilatation means more blood will be flowing across these areas. It is not getting any oxygen. So the shunt increases. Intrapulmonary shunt
increases
because of IPVDs. That is one of the theories that is put forward. What is the second theory that is put forward? Why there can be hypoxia in these patients? What happens to RBCs which are passing in the center of these dilated vessels?
It gets stagnant, stasis.
No, there won't be any stasis because the distance from the alveoli to these
alveolar capillary disequilibrium theories.
Diffusion problem will occur, isn't it? Because the distance from the alveoli into these, the RBCs which are in the middle of these dilated vessels will increase. And these RBCs may not be oxygenated. So that is second reason that has been put forward why these patients have hypoxia, in patients with hepatopulmonary syndrome. So that is why. And these, problems occur more in the sitting posture rather than in the lying down posture. The amount of shunt increases in sitting posture rather than in the lying down posture. Because the amount of shunt increases in the sitting posture, the saturation will come down in sitting posture. Once saturation comes down in the sitting posture, the respiratory center gets activated. The patient will have tachypnea and also dyspnea. That is why which is called as platypnea. Now you understand, isn't it?
Yes,
Why?
yes.
And also because the saturation falls in sitting posture, it is called as orthodeoxia. Ortho means posture. Orthodeoxia. In the sitting posture, saturation is falling, which is called as orthodeoxia.
Deoxy.
So that is what one of the problems. So how do you know that the patient has hepatopulmonary syndrome? What is required to do for knowing whether, what investigations you have to do to know whether the patient has got hepatopulmonary syndrome?
Orthodeoxia test can be done. We can ask the patient to
That
lie.
already we have discussed.
Yes,
Okay.
yes.
Any blood investigation?
Hypoxemia,
What blood
room air ABG we can take.
Yeah, room air ABG, you can do very good. So what happens to the alveolar to arterial partial pressure gradient of oxygen?
Gradient will be decreased.
It will be increased. How much?
Yes.
Increased.
What is the
More than
normal
1/5.
gradient? What is the
More
normal
than 80.
gradient? Usually less than
Uh,
50 millimeters of mercury. So in these patients, it will be increased to more than 15 millimeters of mercury. So AFPO2 gradient more than 15 millimeters, that is one. And what happens to the PaO2? Based on PaO2, you classify these patients into three different grades. Grade 1, 2, 3. What is grade 1 or mild hepatopulmonary syndrome, moderate hepatopulmonary syndrome.
Grade 1 is more than PA.
PO2?
PO2 is more than 80 is grade 1.
Yeah, more than PaO2,
60
more
to
than
79. 60
Yeah,
to
very good.
79 and less than 60.
Less than 60 is
Grade
severe, and very severe is
Less than 50.
less than 50.
50.
Actually, it is more than 80 is mild. 60 to 80 or 60 to 79, as you said, is moderate. 50 to 60 or 50 to 59 is severe. Less than 50 is very severe.
Very severe.
Very severe. So that is a PaO2. Based on the PaO2, you should know. So these patients may be hypoxic. One. What is the other pulmonary condition? I told about the portopulmonary hypertension. In 50% of the patients, they can have portopulmonary hypertension.
Hypertension.
So what is this portopulmonary? When do you say a patient to have pulmonary hypertension?
More than more than 30. More than 20 millimeters of mercury.
Which more than what?
The pulmonary artery pressure.
Is it systolic pressure or diastolic pressure of the pulmonary artery? Or is it mean pulmonary arterial pressure?
Mean
pulmonary artery.
Yeah, MPAP. You should go with mean
Yes.
pulmonary arterial pressure more than
20 millimeters of mercury.
more than 25 millimeters. You call it as pulmonary
Hypertension.
So how do you grade this? Mild, moderate, severe?
More than 40.
25 to 35 is mild. 35 to 45 is moderately severe. And anything more than 45 is severe. Portopulmonary hypertension. The patient has portopulmonary hypertension, his morbidity and mortality will be very high compared to having only hepatopulmonary syndrome. That is why you have to differentiate whether the patient has portopulmonary hypertension or hepatopulmonary syndrome. So these are very important. So we'll discuss tomorrow about the involvement of other organs because of portal hypertension, how they affect our anesthesia and anesthetic management of this patient tomorrow at 5 o'clock. So read more, you should answer better. Tomorrow you should answer. You know the things, but you are not able to answer today somehow, isn't it? So tomorrow I expect better answering. Anyway, we'll Any doubts till now what we discussed? Because another 2 minutes are there. Any doubts for anybody? Anybody has put any thing in the chat box? Chat box is empty. Nobody is asking any questions. So you should always ask questions. You should have a lot of doubts. Do you have any doubts, you, Geeta and Harini? You have read about liver and anesthesia, isn't it?
Yes, sir.
You have been given almost 10 days to read. So any doubts you developed, you can just ask now.
Nothing as of now, sir.
Yeah, tomorrow you're going to ask?
Yes, sir, tomorrow.
Okay, you first thing you have any doubts, tomorrow we'll discuss.
Yes.
And we'll go for further discussion.
Yes,
And
sir.
anytime you ask your friends about any doubts they have, okay. And tomorrow I expect better answering.
Yes, sir.
Because 10 days, only one system you have to read, and how difficult, isn't it? It will become very difficult for you in the exams, isn't it? So that is why continuous reading, continuous discussions are very important. What is very important now, you have read, but the thing is you are not able to recollect many things and answer. So when you present like this and then you discuss with the examiners, you'll know better and your confidence will increase. And many of the questions which you thought that may not have been asked, now you realize what all the questions that are asked and how to answer. Isn't it? It's a good thing that you people have presented. Always keep presenting to many of the different teachers so that your confidence will increase, and you also know, so different kinds of questions will be asked by different examiners, so that you'll get exposed. Okay.
Yes, sir. Yes.
So tomorrow we'll meet again at 5 o'clock. So
Yes,
you are not happy with your net. Tomorrow you'll have to improve with your net.
Yes,
Suddenly,
yes, sir. We'll get it sorted. Yes, sir.
okay.
Yes, sir.
Yeah. Okay. Thank you.
Thank you, sir.